T-wave inversions. A T-wave inversion may occur in four conditions: abnormal ventricular conduction, strain pattern in ventricular hypertrophy, myocardial ischemia, and generalized T-wave inversions in chronic pericarditis. So if ventricular conduction is normal, that is QRS complex is normal, and if there is no hypertrophy of ventricles with strain, then T-wave inversion strongly points to myocardial ischemia. Now first we will consider aberrant ventricular conduction. Normally, when impulse is distributed through normal conduction pathway, the T wave is in the same direction as the main QRS complex. But when intraventricular conduction is abnormal, the T wave is opposite to the main QRS complex and hence inverted. Here are a few examples. This is a ventricular premature beat. Note the wide QRS complex and inverted T wave. In this strip, we see multifocal ventricular premature beats. The first beat is normal and second and third beats are ventricular premature beats. Note that the T wave is opposite to the direction of the main QRS complex. This is an ECG of left bundle branch block. Note the RR' pattern, wide QRS complex due to aberrant ventricular conduction, and inverted T wave. This is a complete heart block with ventricular rhythm. Note the regularly occurring T waves and independent QRS complexes which are wide and bizarre with inverted T waves. This is another example of aberrant ventricular conduction in WBW syndrome. Note the delta wave, that is a slurring on the upstroke of R wave, and the inverted T wave. All these are called secondary T wave inversions, secondary to aberrant ventricular conduction. They have no other significance. Now let us see the T wave inversions in ventricular hypertrophies with strain. This is left ventricular hypertrophy with strain as seen in lead V6. Note the tall R wave of left ventricular hypertrophy. This is right ventricular hypertrophy with strain as seen in lead V1. Note the R wave in V1 suggesting right ventricular hypertrophy. Now we come to the ischemic T wave inversions. The T wave of myocardial ischemia is very typical. Normal T wave has asymmetrical limbs and flat top, but in ischemia it becomes symmetrical and pointed like an arrowhead. First we will consider a patient who is in acute chest pain. Mild ST elevation with deeply inverted and symmetrical pointed T waves is typical of fully evolved myocardial infarction. The T wave remains inverted for about 3 months after the infarction. This ECG shows deep T wave inversion with ST segment depression in leads V3, V4, V5 and V6. This T wave inversion with ST segment depression in chest leads suggests a subendocardial infarct. Similar changes are seen in 1 and AVL also, subendocardial infarct. This is a positive stress test. Note the ischemic T wave inversion and ST segment depression in leads V5 and V6. Another cause of chest pain with T wave inversion is an acute attack of angina. The ST segment is depressed with T wave inversion in lead V5, but this change is transient and will return to normal after the attack subsides. The fifth cause for T wave inversions with acute chest pain is pulmonary embolism. Inverted T waves with raised ST segment as seen in myocardial infarct are seen in leads V1 to V3. This picture with inverted T waves in 3 and AVF suggests acute pulmonary embolism. but these changes are not diagnostic and have to be supported by clinical and other evidence. If the inverted T waves are seen in patients without acute chest pain, they suggest myocardial ischemia, and their location tells the area of ischemia. T wave inversion seen here is in lead V5. This is typical of chronic angina. This ECG shows T wave inversion in one AVL V5 and V6. It indicates myocardial ischemia in anterior wall, probably narrowing of anterior descending branch. This ECG shows T wave inversion in 2-3 AVF. This indicates ischemia in the inferior wall, probably narrowing of posterior descending artery. Now observe this ECG. The T waves are inverted in all chest leads. They are also inverted in limb leads. Generalized T wave inversion is seen in the second phase of acute pericarditis. Tall T waves. The normal variations in the T wave amplitude are often confusing, and generally T waves should be considered pathological if they are more than 10 mm tall in the chest leads and more than 5 mm tall in the limb leads. In the evaluation of tall T waves, the associated ST segment changes are very important. The tall T waves are most noticeable in the chest leads. When tall T waves are seen in chest leads, first look at inferior wall leads, that is 2, 3 and AVF for inferior wall infarct. Here leads 2 and 3 show inverted T waves with Q wave in lead 3, suggesting that there is a recent inferior wall infarct. So the tall T waves is a reciprocal change in the chest leads. Now this ECG shows very tall, narrow and peaked T waves. These are typical of hyperkalemia. Note that they are seen in all the chest leads and they are also seen in the limb leads. So this is hyperkalemia or raised serum potassium levels. This is another ECG of hyperkalemia. Note the tall peaked T waves more than 10 mm high in all the leads. Tall T waves with elevated ST segment are seen in two conditions which we have already studied. Number 1, acute myocardial infarct on the first day and acute pericarditis when seen in all leads. If the tall T wave is associated with ST segment depression in the chest leads, note the leads involved. If seen in leads V1 to V3, it is diagnostic of a true posterior wall infarct. And if seen in most of the chest leads, it is probably due to subendocardial ischemia. Not infarct but subendocardial ischemia. So tall T waves with depressed ST segment in chest leads is seen in posterior wall infarct and subendocardial ischemia.